Welcome to the last session of the meeting. So glad to see that there's more than 6 people in the room, so thank you for coming. I'm Patrick Flume. This is a session that we've now done for a few years, even did it unrecorded in the last couple of years, in which 3 journals have come together to highlight an article published in each of our journals, but the point of the session is not so much to just highlight the article, but also the editorial process and nuances as to why it got up, what we were focused on, and so forth. So the basic format is that we will have the author present the article and then followed by an editorial discussion. We'll then open it up for some questions and answers, and after we do all 3 journal articles, then we're going to talk about some highlights of issues relevant in the publishing industry today. So I serve as editor-in-chief for the Journal of Cystic Fibrosis, and I'll just pass it on.
Thanks, Patrick. My name's Alan Smith. I'm the Professor of Child Health at the University of Nottingham, and I have just stepped down as Editor-in-Chief of Thorax, along with 2 colleagues, which means I have an extra 2 days in my week to do stuff. I think Patrick's touched on what we're aiming to get from this, which is to get under the bonnet of the publication process as it affects the researcher. I hope you'll find that useful. I think it's useful for early career researchers, mid-career researchers, and late career researchers.
Hi, and I'm Bonnie Ramsey, and I'm a professor of pediatrics at the University of Washington, based at Seattle Children's Hospital. And I am the associate editor for cystic fibrosis for the American Journal of Respiratory and Critical Care Medicine, more commonly known as the Blue Journal, and I'm very excited to be here. So with that, I think we will go ahead to our first author and reviewer session.
And so we're going to start with an article from the Journal of Cystic Fibrosis, and I'm going to introduce Jess Pittman, who's an associate professor at Washington University, where she also serves as director of the, did I get fellowship program correct or no?
APD for fellowship,
co-director of the TDC, and also involved in DEI at the program as well. So she's going to present her article on the impact of azithromycin on serum and inflammatory markers. So Jess?
Hi, everybody. Thank you to the organizers for inviting me to speak today. So I'm speaking on the impact of azithromycin on serum inflammatory markers in children with CF and new Pseudomonas. And I'm speaking on behalf of my co-authors, who you can see here. If we choose to move. No relevant disclosures. Before we start, I would just like to urge the CF Foundation to commit to ensuring the future meetings are held in locations where elected leaders understand the importance of reproductive freedom, gender-affirming care, voting rights, anti-racist action, healthcare as a human right, and the sanctity of the physician-patient relationship. Whether we like it or not, health and healthcare are inherently political, so I urge you all to vote. So moving on to the article, background here. So chronic azithromycin therapy in CF has been used for a while, and it's been shown to improve outcomes in children with CF, both with and without Pseudomonas infection. But the mechanism of action is unclear. And the most common things that are shown in terms of outcomes are a decreased risk of pulmonary exacerbation and improved body weight over time. The AZ0004 study showed a decrease in systemic markers of inflammation in children without Pseudomonas who were treated with azithromycin. At 4 weeks, you can see there was a decrease in 5 different inflammatory markers, including high sensitivity CRP, myeloperoxidase, calprotectin, serum amyloid, and absolute neutrophil count. And then at 24 weeks, only 3 of those remain significantly decreased: calprotectin, serum amyloid, and ANC. Well, the data that I'm presenting is a sub-study of the optimized trial. The optimized trial demonstrated significant improvement in children with CF and new Pseudomonas, so slightly different than the AZ trial, treated with chronic azithromycin versus placebo, as well as inhaled tobramycin for 18 months. So Optimize showed a risk reduction of 44% for exacerbation with azithromycin versus placebo. And importantly, what they really showed was a delayed time to first exacerbation in the azithromycin group, as you can see in the Kaplan-Meier plot here, with the azithromycin group in the dotted line. And Optimize also showed an improved weight in subjects who were on azithromycin versus placebo. So for this sub-study, we looked to analyze systemic inflammatory markers collected in the Optimize trial. Optimize enrolled 221 children aged 6 months to 18 years with newly acquired Pseudomonas. And they were randomized again to receive inhaled tobramycin in all groups, plus either azithromycin chronically Monday, Wednesday, Friday, as our typical regimen is, or placebo for a total of 18 months. The end analysis cohort ended up being 129 subjects who were randomized, enrolled, and contributed inflammatory marker data before the study was terminated early after demonstrating early efficacy. The markers that we investigated largely came from that AZ0004 paper, including myeloperoxidase, CRP, calprotectin, absolute neutrophil count, and white blood cell count. And our samples were taken at baseline, 39 weeks, and 78 weeks. All of those variables were log transformed, and then we used two-sample t-testing to compare both change from baseline in the azithromycin and placebo group, and then difference between those groups at each time point. This is just a grid of our enrollment. So as I mentioned, 221 subjects were randomized, essentially equally into the azithromycin and placebo groups. Our analysis cohort included all subjects with inflammatory markers at baseline and at least one follow-up visit, relatively equally split between azithromycin and placebo for a total of 129 subjects. We did perform a sensitivity analysis. The sensitivity cohort included subjects with inflammatory markers at baseline and at least one follow-up visit prior to unblinding, and that's why the sensitivity cohort is slightly smaller. There were no significant differences in the analysis when we looked at the sensitivity and analysis cohort. In terms of our characteristics, our groups were very similar between the azithromycin and placebo group, as you can see here. There were no significant differences in age, genotype, baseline lung function as measured by FEV1, CFTR modulator use, or other enrollment characteristics. In terms of our findings, we found a decrease in CRP from baseline to week 39 that was significantly higher, so a more impressive decrease in the azithromycin group compared to the placebo group. But there was no significant difference in the change from baseline between the two groups at 78 weeks. There was no significant change from baseline or significant difference in change between the azithromycin group and the placebo groups at either time point for the calprotectin, myeloperoxidase, ANC, or total white blood cells. So really what we found is a transient change in the CRP. The primary limitations of our study were that we were unable to assess lower airway inflammation as we didn't have access to any bronchoalveolar lavage samples. And early termination limited our ability to examine associations between the change in inflammatory markers and other important clinical outcomes. It also limited our subject size a little bit. Or excuse me, our sample size. So to sum up, our data showed a small transient decrease in CRP in children with CF and new Pseudomonas treated with azithromycin versus placebo, again, in addition to inhaled tobramycin, that was present at 39 weeks and no longer evident at 78 weeks. Importantly, there were similar rates of Pseudomonas eradication, recurrence, and persistent in the azithromycin and placebo groups. So it seems unlikely that either Pseudomonas itself or the impact of azithromycin therapy on Pseudomonas accounts for the change in CRP. When thinking about our findings in comparison to the AZ0004 trial, so that study showed a significant decrease in 5 markers at 1 month and 3 markers at 6 months. How was Optimize different? Our subjects were younger, so the AZ study was 6 and up, and ours was 6 months and up, not 6 years. So it's possible that our patients had a lower burden of lung disease at baseline, and therefore we might not have room to see as much change. Our subjects also had newly acquired Pseudomonas as opposed to no Pseudomonas in the azithromycin study, and therefore they might have a different inflammatory stimulus, and therefore we're really measuring different processes. And finally, this study did follow subjects 3 times longer. So again, our measures were at 10 months and 18 months, 18 to 19 months, as opposed to 1 month and 6 months. And so we could really be looking at a return to baseline levels of inflammation with a transient impact of azithromycin. Wrapping up, we saw a transient decrease in CRP noted in children with CF and new Pseudomonas treated with azithromycin versus placebo, both treated with inhaled tobramycin, which lends some credence to the suggestion of an immediate but not sustained immunomodulatory effect of azithromycin in our patients with CF. This could explain the delay to first pulmonary exacerbation that was seen, again, if you think back to that Kaplan-Meier curve from the optimized study, as well as a lack of difference in overall pulmonary exacerbation rate seen in the optimized study. And it's possible that there's a return to baseline levels of inflammation somewhere in the first 12 to 18 months if we sort of merge together the AZ004 study and the optimized study. And obviously, further study is needed to elucidate mechanism of action and duration of action in azithromycin in children with CF. And with that, I will thank my co-authors and I think pass it on to Dr. Vatchin.
Before I bring our discussant, are there any questions for clarification?
Was the 28-day just one course or cycles?
Do you want to repeat the question?
Yeah, so the question was about how the inhaled tobramycin was used. It was a cycle, on and off.
All right, thank you, Jess. So now, I don't know that I really need to introduce Felix. I mean, Felix does everything. But Felix has served as, in this case, he's associate editor, the handling editor of this particular paper, and so was asked to handle this. And so Felix, I'm going to encourage folks to send in their questions. We will have a microphone for questions afterwards. I think if you just hit that left button.
Yeah, so I'm just gonna go. So this is me. Just in case you don't remember me. When I was younger, actually, so I should have changed my picture at some point in time. So I'm going to take you through the editorial process a little bit in terms of the initial thoughts about this manuscript, but then also the review process. And so the manuscript was submitted October 25th and then reassigned by Patrick on October the 30th. And you say, well, that was a quick turnover for reassignment, but the associate editor that was supposed to handle it initially didn't do it within 24 hours. So, and Patrick is a very impatient person, and he wants to keep the journal on a tight timeline. So he reassigned it to me, and I invited the reviewers on the next day. And the reviewers actually did a good job in completing this in a short period of time, within 2 weeks. And so we could come to an editorial decision for the first revision on November 23rd. And we received the revised manuscript on February 24th. And since the authors did such a wonderful job in addressing all the questions, we could actually accept it on the next day. So when I receive a manuscript from Patrick, then Patrick has already taken a look at it, and sometimes it comes with comments of asking me, do you think this is really worth it? And sometimes it comes without comments. And in this case, in any case, I will take a look at the manuscript and ask myself a couple of questions. And these are 3 of the key questions. Does this study actually provide a new finding that is relevant? And is the study design appropriate to answer the research question, which is certainly important? And is this the right target journal for this work? Because sometimes the study is certainly of interest, but may not be the right, the audience of the Journal of Cystic Fibrosis might not be the right target audience for that work. So how did that look for the presented study? So So does the study provide a new finding? It was certainly not the first study in this area in terms of looking at inflammation and in the context of azithromycin, and Jess has pointed this out very nicely in terms of the previous study that I was actually involved with. But it was the first to assess this over this longer time period, and that was really the novelty of the study and the interesting component of the study, because there has always been concern that azithromycin might not work for such a long period of time in terms of its anti-inflammatory effect, and that might wane over time. And it has not previously been previously assessed in the context of newly acquired Pseudomonas. Was the study design appropriate to answer the research question? This was really a well-designed RCT, which was already published at that time point, so the RCT was certainly of good quality. And the add-on study was also designed, and there was enough data to make sure that the subpopulation that was looked at was representative of the overall population. Was that the right target journal? That was really not a question. It was the right target journal. So what were the major points during the review process? I think it's always a bit of a balance if you provide an add-on study, that it has enough information about the core study for the reader to not necessarily have to go back to the initial study to understand the details of it. And it was a relatively short and concise report, which on one hand was good, but so in the review process we asked the authors to provide a little bit more clinical context for the study and clinical context for the patients. We wanted them to address potential selection bias for the subcohort, because these inflammatory markers were not done in every subject. And then the question came up, is this all caused? Is there a causal relationship between pulmonary exacerbation? And because, as Jess has shown you, that was one of the signals of the study, of the initial study, that there was a reduction in pulmonary exacerbation. But the chicken and egg question is, of course, difficult to answer, but we certainly wanted this to be addressed in the discussion. And then we wanted to enhance the limitation section that Jess already mentioned, in terms of this was a study based on serum rather than doing intense sampling directly from the airways. So, and in the end, the key points of the study came out nicely in the revised manuscript, which I listed here. The anti-inflammatory effects of azithromycin may not be sustained over time. This is certainly not the last kick at this can in terms of addressing this question, but it certainly is one step along this road. And the best way to monitor that clinically is still to be defined. So it still raises this question of the balance of how long should we treat patients with azithromycin, and should there be some breaks in treatment because of their lack of effect after periods of time. But this was not what the study could assess. But overall, after the review process, we were all very happy that the study provided an important piece of information along this line of evidence. And this is where I'll stop. Thank you very much.
All right, thank you, Felix. Why don't you stay here? We'll open up for questions, or if there's some coming across. But showing the timeline, I just wanted to bring up a couple of points that's very important in the editorial process. One of the metrics that we look at is how long does it take from a paper was submitted to get turned around completely? And realize there's a lot of parts in there. There's time that it's with the editors, then going out to reviewers, back to the editors, then back to the author, back to the editors, and so forth. So in this case, the turnaround time from editors and reviewers was very fast. At least in my mind, that was very fast. So that was great. The longest duration there was it going back to the author, and sometimes that's because what we've asked for is additional analyses, additional work. Authors will often write and say, can I have more time because you've asked for us to do a lot. But that factors in if you ever look at our metrics to see what goes into that. The second key point is the revision came in and the authors did a good job of responding to the comments. We don't always send it back out to reviewers, so it did go back to Felix to see if he was satisfied that the comments had been addressed, and so thank you. We don't want to burden reviewers. All right, questions? State your name.
This is Nicole Hamblett. Mine is not a question, but a comment. And I will actually say that, and I'll take some accountability for the duration of time in between in between the resubmission process. Because, in fact, this was during COVID, and we had staff turnover and statisticians and so forth over that time that actually, I think we need to be cognizant of, over the last 2 years behind the scenes, especially when we're relying on, revisions that require more analyses. So I think it's not all on the primary author. I'll just.
I just want to say, as an editor, as associate editor, it's actually more important that when the work comes back, that the team has done a good job in addressing all these questions adequately, which often is not the case, right? Often they try to wiggle their way out of of this and do not necessarily address all these questions. So I think and for me, it's not so important how long that takes, and it's not something that a journal should be rated on in terms of this time delay. I think it's really the turnover in the editorial process. And but I think what was really nice in this manuscript resubmission is that I could go through all the points, and every point was taken seriously and addressed. And that is not a situation where it's very easy to say I don't have to go back to the reviewers to bug them again to look at it.
So we beat on the editors for them to do their job. We plead with the reviewers. We don't beat on the authors. You need more time, that's okay. Just don't take 2 years. Any other questions in the room on this particular paper or the handling? Everybody's getting worn out. So thank you, Felix and Jess, and now I'll hand it off to Bonnie.
That's quite all right. Hi. So now we're moving to the Blue Journal, and our talk today is entitled Trikafta Rescues CFTR and Lowers Monocyte P2X7R Induced Inflammasome Activation in Cystic Fibrosis. So again, on the inflammation theme, and our speaker today is Dr. Jerry McIlvaney, who comes from Dublin, from the Irish Centre of Genetic Lung Disease, where he's a professor of medicine. And so I look forward to his discussion, and then we'll have a review from Dr. Coles in a minute.
That's not me, actually. You got the wrong person.
Oh, what?
That's not me.
Oh, no, that was the previous one. Oh, let's see, let's go back here. Let's see, there you are.
Okay, there. I'll start.
There
Yeah.
you go. That should come up.
That's lovely. Thanks very much, Bonnie. Okay, so thank you all very much for inviting me here today. And Bonnie has given me very specific instructions for what I have to do, so I'm quite happy to proceed with those. So these are my disclosure slides. And as Bonnie has mentioned, we're going to talk about Trikafta and its effect on monocyte P2X7R induced inflammasome activation in CF. So this study stemmed from previous study we had done in our lab looking at neutrophils in CF, and we had shown that the CF neutrophil underwent metabolic reprogramming, and specifically a shift towards aerobic glycolysis. And this was driven almost entirely by LPS. And we had published that in the Blue Journal. And people said to us, well, the neutrophil's not the big inflammasome, why not go for the monocytes or macrophages? And that's why we looked at monocytes and macrophages. Monocytes are quite different than macrophages, than neutrophils, and theoretically, or classically, monocytes require two signals for inflammasome activation. via LPS through toll-like receptor 4, and via extracellular ATP through P2X7R. Now, there is an alternative inflammasome activation pathway described in monocytes, but this is the one we decided to look at. So, if you can see it here, we first looked at how P2X7R modulates inflammasome activation in monocytes. And we looked at NLRP3 messenger RNA, and we looked at healthy control monocytes and CF monocytes in blue. And you see at rest, the CF monocytes have a little bit extra NLRP3 messenger RNA, but when you stimulate them with LPS and ATP, there's a significant increase, more so than a healthy control monocytes. Now that is abrogated when you use a P2X7R inhibitor. In this case, we use A438079, and that brought it back down to the normal levels, the healthy control levels. And we showed this with both messenger RNA and with protein. And then we went downstream of that, and we looked at caspase-1 and IL-1 beta. And again, we used healthy control monocytes and CF monocytes. Again, you'll notice that the CF monocytes seem to have a little bit extra caspase-1 activity. When you stimulate with LPS and ATP, it goes up quite significantly, more so in the CF monocytes than the healthy control monocytes. And then when you inhibit P2X7R, it comes down to the healthy control stable setting. And then we looked at IL-1 beta, we looked at secretion of IL-1 beta, and again you can see monocytes secrete slightly more IL-1 beta at rest than in CF, than in healthy controls. When you stimulate with ATP and LPS, significantly increased IL-1 beta secretion, more so than healthy controls. And then when you inhibit ATP signaling through the P2X7R receptor, you get this coming down to normal. Now you will notice IL-1 beta secretion does not come down entirely to the normal level. And that's something that was quite of interest to us and something which I'll discuss later on. So what is the effect of CFTR inhibition on P2X7R expression? Because in CF, to our way of thinking, the big conundrum is it inflammation or the CFTR that's causing the problem, or a mixture of both. And it's usually a mixture of both. But what we did here was we used a CFTR inhibitor on monocytes, and we found that over time you could see intracellular chloride secretion was significantly affected. Intracellular chloride was significantly increased in CF monocytes exposed to a CFTR inhibitor. And similarly with that, you get decreased chloride secretion. So increased chloride intracellularly and decreased chloride secretion. Now, hand in glove with that, we looked at P2X7R messenger RNA, and again, with inhibition of CFTR, you get increased expression of P2X7 receptor. So we carried this a little bit further. We looked at protein, and we looked at P2X7R protein in monocytes exposed to a CFTR inhibitor, and again, you increased P2X7R protein expression as well. So that was the interesting thing that we found. So if you have less CFTR activity, you have more expression of P2X7R at the message level and at the protein level. And then we looked in vivo. And in vivo, we looked at people, healthy control individuals, people pre and 3 months post-Trikafta therapy, and then people with CF who had had a transplant but were not on Trikafta. So again, we looked at a number of things. We looked at NLRP3 messenger RNA, P2X7R messenger RNA, and you can see in healthy controls, it's less than in CF individuals pre-Trikafta therapy. But when people are on Trikafta about 3 months, P2X7R expression is now down to the normal control level. In distinction to that, people with CF who've had a lung transplant, their P2X7R expression in monocytes is much the same as people who are pre-Trikafta. And that was interesting because in our previous study in neutrophils, we got a different response. So we looked at this a little bit further, and we looked at P2X7R protein expression, and again we saw a similar response. So people with transplants behaved as people pre-Trikafta, but when you get Trikafta, a significant decrease in your P2X7R expression at the message level and also at the protein level. So then we looked at a few other things. We looked at CFTR expression post-Trikafta. We found that pre-therapy monocytes had significantly decreased CFTR messenger RNA. Post-Trikafta, there was more CFTR messenger RNA, and the people with transplants behaved just the same as pre-Trikafta people with CF. And we showed this with protein as well. So both messenger RNA and protein showed that. And then we started to look at ion changes. And I think the ion changes are really important because it gives us an idea about what's fueling this. So again, if you look at extracellular chloride secretion, you see a healthy control. People with CF pre-Trikafta, and then post-Trikafta, it's up in the normal range. But again, people who are post-transplant but not receiving Trikafta, it's back quite low. And again, we looked at intracellular calcium. Intracellular calcium was quite high in people with CF pre-Trikafta. Post-Trikafta, it came down significantly. And another really interesting thing for us was extracellular chloride. So in other words, potassium. Potassium efflux is a really significant part of the inflammasome activation process. And we found that people with monocytes pre-Trikafta had significant extracellular potassium efflux, which was significantly abated when they were given Trikafta for just 3 months. We then looked at Trikafta's effect on ATP, LPS-induced inflammasome activation. And it's a bit small, but you can see it here. You've got healthy control individuals, people with CF pre-Trikafta, and then the red group, people with CF 3 months post-Trikafta. And you see at rest, as we said before, NLRP3 slightly increased in people with CF without any particular stimulation, but post-Trikafta, it's down to within the normal range. And again, when you stimulate with LPS and ATP, significant increase, but post-Trikafta, the increase is much the same as the healthy control. And you see that with protein as well as in messenger RNA. And then we look at caspase activity, and you can see, as we said before, caspase activity slightly increased in monocytes pre-Trikafta. Post-Trikafta, it's down to the normal range. And again, you can see when you add the LPS, you get a significant increase in caspase activity in people pre-Trikafta, but post-Trikafta, it's down in the normal range. What's the effect of inflammatory mediators? Now, we did this because although we attribute a lot of things to CFTR, we have to realize, I think, that Trikafta and before it, ivacaftor, had an anti-inflammatory effect on inflammatory mediators as well, systemically and in the lung. So we looked at this again, because this might affect inflammasome activation, and we looked at LPS in the plasma, pre-Trikafta and post-Trikafta, significant drop. We looked at ATP in plasma, pre and post, significant drop. And then we also looked at IL-1 beta in plasma, pre and post, significant drop. So again, a lot of this is due to CFTR, but a significant amount may be due to anti-inflammatory effects of Trikafta as well. So our initial conclusions were that ATP affects inflammasome activation in CF monocytes through P2X7R. P2X7R expression is regulated by CFTR activity. It's increased when your CFTR is not working. Trikafta restores CFTR activity in monocytes with reduction of P2X7R, and LPS-ADP-induced inflammasome activation in CF monocytes is reduced by Trikafta therapy. Now, Bonnie said to me, why did you send this to the Blue Journal? And there's a number of reasons we sent it to the Blue Journal. Number one, it's a very good journal. It's a very high impact factor. But a lot of our previous work had been sent there as well, and we thought it was a logical conclusion to look at stuff in the Blue Journal. Our previous neutral inflammasome paper had been published in the Blue Journal. And during COVID, when we'd been forced into the COVID process away from our normal habitat, we also published inflammation processes in the Blue Journal as well. And we knew from previous experience that you get very good reviews in the Blue Journal. They're helpful, they're not punitive or pejorative, they're trying to put you in the right direction, and we appreciated that. So, with that as background, I just briefly go through some of the reviews that we got in the initial iteration and how we tried to handle them. So one of the things that the authors mentioned is a very good point. They said we had mentioned that people with CF who are not eligible for Trikafta could benefit from inhibition of the P2X7R receptor. And do the authors know if such inhibition would also inhibit any residual chloride secretion through a calcium-activated chloride channel? Now, this is a really smart question, because we didn't know. And there wasn't any data out there. But there was some data. If you look at xenophagocytes, where they co-express a chloride-activated chloride channel with the P2X7R, and you stimulate the P2X7R through ATP, you do get chloride efflux through the calcium activated chloride channel. So knocking off P2X7R signaling per se might not be a great idea in its entirety. The next question we were asked is, do we know the mechanism for decreased gene expression of CFTR? And again, it's a difficult question, but our hypothesis was that was increased intracellular chloride had an effect on CFTR expression. And that had been shown with some other things as well. And as a corollary of this intracellular retention, there was decreased extracellular chloride secretion. And we also know that extracellular chloride also inhibits P2X7R activity as well. So it's a 2-for-1 if you take it like that. Then the question was, do you have a CF control? And we hadn't used it. So our CF control was non-CF bronchiectasis patients, and we utilised people who had PCD and significant bronchiectasis, and we found that their monocytes behaved just like a healthy control monocyte, not like a CF monocyte. And then another really interesting question, is TLR9 and FCR expression being modified? Now, we didn't look at this, but it was a really good question because there's no doubt that what we're looking at is a very specific thing. We're looking at LPS and ATP, P2X7R. But there's lots of other things that activate these things as well. And there's lots of other receptors that are activated in CF. So we're looking at a very specific thing, and we had to temper some of our claims because of that. And that's only correct. And that was a good kick in the butt to us to do that. Another reviewer said, both IL-1 beta, messenger RNA, or protein are still elevated after treatment with A43879 and compared to controls. And that was an absolute fact. The IL-1 beta specifically was still elevated, but it had come down. It had come down significantly, both at the messenger RNA level and the protein level. But it was still up, and there's a few different reasons for that. And I think we tried to put that into the discussion, but it is a complex area. And we do not think for 1 minute that LPS and ATP are the only things subtending IL-1 beta production in this area. So Bonnie also asked me to say how to write a response letter. And the first thing is be humble. I think we all think we've discovered the next Nobel Prize, but we're not. We certainly have not. And in being humble, listen to the reviewers. The reviewers are not out to get you. They're trying to put you in the right direction. And getting you to temper your conclusions are a good thing. And the other thing about being humble is say up front where your problems are. We looked at monocytes, peripheral blood monocytes. We did not look at macrophages. There's a big difference between a monocyte and a macrophage, and we all know that. So preempt that by saying this is what we've done. Get a good statistician, because I think that's one thing everyone needs. See what you can answer from previously published data. I think that's really important because some of the data is already out there. You don't have to repeat every experiment. But be prepared to do extra experiments. They expect that. And one of the extra experiments we did was we didn't just look at chloride secretion, we looked at chloride intracellular retention, and that was important. And if necessary, alter or soften your conclusions, but you have to stick up for what you believe. Thanks very much for your attention.
So are there any questions for Dr. McElhinney before we have Dr. Cole come up? No, I'm not seeing one. So thank you very much. That was great. So now I'd like to introduce Dr. Jay Cole, who's a professor of pediatrics and medicine and the director of the Center for Translational Research in Infection and Inflammation at Tulane School of Medicine. So Jay,
Great.
thank you.
How do I?
And Oh,
Do I just go next?
let's see here.
Hit escape.
Yeah. Okay.
Oh, the next one. Yeah, that's me.
Oh, there. Okay.
Yeah.
All right. Thank you.
Okay, so Bonnie asked me to talk at this session, and I thought I would frame this in what's becoming increasingly mandated by the National Institutes of Health in terms of their rigor and reproducibility and research. So basically, I apply the same policy to grantsmanship as I do for publication. So I have no disclosures except I'm a Kennedy, and apparently I have a pub in Dublin. So it's Kennedy versus McIlvany, okay? Okay, so this is the link to the NIH policy, and rigor pertains to the experimental design, the sample size, controls, variables such as age, sex, and in this case, non-CF controls to look at off-target effects of the drug. Is the approach unbiased? Is it blinded? Are there technical and biological replicates? And then particularly here, we need to attribute something. Obviously, the most rigorous approach is a gain and a loss of function approach. So the fact that the group had data with both CFTR inhibition as well as CFTR rescue with Trikafta showing the same biological phenomenon is strong evidence that there's an effect. And then reproducibility is important, and that comes with sample size and replication cohorts, which is very common, and particularly in genetic studies. So in terms of NIH's policy on reporting results, clinical trials should have a consort diagram. For human data, we generally discourage column bar graphs. We want to see the individual data plots, dot plots, which the authors provided here, and it gives you an idea of is the data normally distributed or non-normally distributed. And with a relatively small sample size that was in this paper, obviously you can't make an assumption of Gaussian or normality. So basically the appropriate statistical analysis would be a non-parametric test. And then for those people that do flow cytometry, which is not too common in CF, but maybe more common as we kind of do more and more immunology and inflammatory studies. This link here is the European Journal of Immunology standards for publishing flow cytometry, which is basically includes your gating strategies. How did you gate on the cells that you're analyzing? So this is just an example of a consort diagram, and we've seen one from Jessica's group as part of her. So here's the published paper. And this cartoon was model here was that Trikafta was regulating P2X7R, and this was data from patients on the drug for 3 months. And the question is, was this a direct drug effect, or was this some other alternative hypothesis? So, as I mentioned, the data presentation in this case. There was some issues with the initial statistics, and to the author's credit, they got a statistical review. And I think, Bonnie, maybe you could clarify, I think the Blue Journal often uses a statistical reviewer in addition to the scientific review, correct?
Yeah, yes, that is correct.
Yeah.
But they also got statistical input.
Yeah. So what are the alternative hypotheses? Well, obviously we know that patients on Trikafta therapy, there could be changes in the microbiome. We know that there's epigenetic regulation of many of these inflammatory mediators, and perhaps that explains. And then I mentioned that there's other upstream regulators of NLRP3 apart from P2X7, specifically the TLR9 signaling, and then particularly the FC receptor signaling. And Niels Hoiby and others have shown that CF patients have lots of anti-Pseudomonas antibodies, and you can imagine that if you go on Trikafta and you reduce your Pseudomonas burden, that maybe those antibodies also get reduced over time, and that could explain some of the data that was in the paper. So this is actually a paper that we published looking at the GOAL study. So this is patients on with G501D mutations, and then we did RNA sequencing on PBMCs at baseline and then 1 month after Kalydeco therapy. And the number one gene was actually TLR4 modulation. But what was really interesting was in this data set, the modulation of TLR4 correlated most closely with the CFQR, not the delta sweat chloride, which suggested to us that the decrease in TLR4 was more related to overall kind of well-being and not a direct drug effect. If it's a direct drug effect, you would think there would be a relationship between the delta TLR4 and the delta sweat chloride, which is obviously the delta sweat chloride is I think most people would believe is a direct drug effect. So this is the paper that shows that FC gamma receptors can mediate TLR4 and SIK-dependent NLRP3 inflammasome bacteria. This is to an intercellular pathogen, Francisella, but may be relevant in cystic fibrosis. And then if Trikafta has a direct effect on P2XY7 and inflammasome, then it should be able to be demonstrated in vitro. And the authors came back and actually, this is so typical of journal. I review for JCI, JXMed, immunity, cell, and sometimes the most interesting data is the supplemental figures. So read the supplementary data. But so this is the supplementary data where they showed modulation of both P2X7R and IL-1 beta production, which again supported their working hypothesis. And then what's interesting here though is the IL-1 beta mRNA depicted. I need my glasses here. Here, it's not completely responsive. So in a way, a trainee may be disgruntled because they didn't find the magic bullet. I think this is actually the perfect result as a trainee because it means that you're onto something and that you're partially correct, but there are other mechanisms that may be at play, and so that's your next grant. That's it gives you ammunition for the next story. So it's rare to hit a home run in science, and but as long as you can identify an effect size that you can study, and then find the other indirect effects. So CFTR corrector modulators have profound effects on immune cells, and some of this is CFTR dependent, but there's likely also independent effects. So epigenetic modifications, obviously BMI is changing, nutrition is changing, likely the microbiome is changing both in the gut and the lung, and there may be changes in adaptive immune responses such as antibodies, or actually we heard, I think, from Dr. Saavedra that there's changes in T-cell responses after Trikafta on Thursday. So it's an exciting time to be a CF researcher, and it'd be interesting to find out what correlates really track well with good responses. So I thought I gave you a flavor of what it's like. I think Felix gave you an idea of what it's like to be an editor, and I gave you a feeling for what it's like to be a reviewer. So thank you.
Yes, thank you. So as the associate editor, first of all, I want to thank Jay, because Jay is a phenomenal reviewer. And remember, reviewers are volunteers, so and it takes a lot of time and effort, but you learn a lot at the same time. So I was excited about this paper because since Trikafta has come, there really hasn't been as clear a message on the anti-inflammatory effect as there has been like on sweat chloride or FEV1. And this paper, although it's simplistic, as Dr. McIlvaney said, to say it's just external ATP and LPS, it really was looking at mechanism of action and actually showing some of the changes both in ions as well as inflammatory mediators. And so that's what I liked about it. And it had its limitations, which every paper does. Not the least of it needed a statistical input, but they responded. They responded appropriately and quickly, and came out with an excellent product. So I think this is a good example of how the review process can strengthen a paper. So any questions for either Jay or Jerry? Oh, okay.
Thanks, Bonnie. So I think this is for both potentially, but it's from Nauman Chowdhury. Do you know if there's a phenotypic variability in CF disease, and could it be explained by variability in neutrophil responses, or do all neutrophils behave similarly? In other words, why do some people have severe bronchiectasis versus others? How does this correlate with various infections, and how can we differentiate this clinically and make it relevant in practice to how to treat them? Antibiotics, steroids, or something else like modulators? So there's a few questions in there.
You want to take it?
No, okay. You take it, Chair.
So thanks very much. That's a really, really interesting question, because some time ago we had shown that neutrophil degranulation was abnormal in cystic fibrosis. So, for example, secondary and tertiary degranulation was decreased, but primary granules were increased. So it increased neutrophil elastase and MPO being produced. So that was quite interesting. But we'd also shown that in people with the G551D mutation at that time, when they're on ivacaftor, this was normalized. So that was really interesting. Now, as some people have mentioned before, when we were doing this experiment, it was during COVID, so we couldn't get into the lung. But eventually we got into the lung. And we haven't published the data yet, but it's interesting. Trikafta has an enormous effect on neutrophils in the lung. It's got an enormous effect on neutrophils in the lung. And that's going to have a big effect, I think, on macrophages in the lung. Because Jay has mentioned that the various things that can affect your inflammasome. One of the ones that we're interested in is a thing called SLIPI, secretory leukoprotease inhibitor. And SLIPI is a very interesting effect on ATP-induced inflammasome activation. SLIPI in the lung is chewed up by neutrophil elastase. Post-Trikafta, it's not so much chewed up by neutrophil elastase. So it's an interesting area. As Jay said, there's loads of stuff for us to do yet, I think.
Yeah, I'll just make a brief comment on neutrophils. So if you do single-cell RNA-seq on peripheral blood, neutrophils are the most heterogeneous population. So even though they morphologically look the same, their transcriptional profiles are quite different. And then that even changes once the neutrophil gets into the lung tissue. And we've known that with eosinophils for a long time, right? People always talked about, you know, to treat asthma with anti-eosinophil blocking drugs, that the tissue eosinophils actually survive longer than the blood eosinophils. So yeah, we have to study the cells. Peripheral blood is helpful, but actually also studying the cells in context, as Dr. McElvany alluded to, is important.
Any other questions? One other comment I wanted to make that I forgot to mention earlier is your use of transplanted patients with transplanted lungs as a control. I mean, obviously their lungs are different, but they still have CF. And I thought that was interesting because I haven't seen that before, but I think that's really a great idea to consider. Oh, okay. Okay. Thank you very much.
We've touched briefly on editorial process, and I think it's probably helpful just to run through what happens in our journal, which is Thorax. And we have a duty editor who will be one of the editors-in-chief, and that person will look at all the manuscripts landing on their desk in that week. And we've talked a little bit about COVID, and what we experienced in Thorax during COVID was that our manuscripts per week went from 25 to 50, so we were getting 200 per month. And what follows from that is that you need to do some desk rejects, so there will be some immediate rejects in any journal. In our journal, the immediate reject rate is about 70%. And that's a tricky thing to do because you need to put yourself in the shoes of the author and think, why are we rejecting this, and is it a solid reason for doing so? And I guess when the next paper came across my desk, there was no chance of a desk reject because I could see that the question was very important, and that was the potential for interaction between azithromycin and tobramycin, which would mitigate or diminish the antibacterial effects of tobramycin. And that's something that I and a lot of colleagues have been concerned about and been worried about for quite some time. So it's a great pleasure to introduce Dave Nichols, whose paper on the TEACH study looking at the interaction between tobramycin and azithromycin came across my desk. One of the things I knew I was going to have to do was justify this at the hanging committee to a group of editors who also were lobbying for critical care and lobbying for sleep medicine, whereas I was lobbying for CF. So I also chose a very strong reviewer who I knew would give me a robust review. But Dave, if you'd like to join me on the platform and present the summary of the paper, let me just get the slides up. So I'm hoping these are going to come in the right order. Let's try that. We good?
Thanks very much, Alan. It's a real pleasure to be here, and the continuity of the papers is unexpected. So the work similarly with Jess, and been fascinated by the work from Drs. McElvany and leukocyte biology and modulators. If you haven't read those papers, I encourage you all to go back and do so. So I'm here to quickly present the results from a clinical trial called TEACH, in which we were testing the effect of using azithromycin and inhaled tobramycin in combination to address Pseudomonas infections in those with cystic fibrosis. Great. Here's my disclosures. Very briefly, the rationale for the trial, as was alluded to by Alan. So we and others had published several non-human studies in bacteria and in animals, finding that azithromycin in these models antagonized the ability of tobramycin to kill Pseudomonas aeruginosa. Azithromycin is well documented to concentrate very heavily in the lung and the airway surface. And as a chronic therapy in those with CF, particularly those with Pseudomonas aeruginosa infection, there was some concern that this may lead to an unexpected or unanticipated drug-drug interaction. And so were we doing the right thing by our patients? We'd also gone on to do some post-hoc data analyses in those with CF, suggesting that combined use of these two medications together was perhaps less advantageous than those using inhaled tobramycin alone, although that was post-hoc and retrospective, and it really underscored a need to do a prospective study where we could rigorously try to understand the clinical implications of that. The trial design looked like this very briefly. Individuals came in on their usual care. They were then randomized to azithromycin or a matched placebo, and then they used that on the randomization period, which is what we'll focus on here for 6 weeks. 2 weeks into that azithromycin or placebo, they then began their inhaled tobramycin product for a 4-week period. We studied those age 12 and older. They needed to have 2 Pseudomonas positive respiratory cultures in the last 12 months and 1 in the last 6 months. I'm glad we're not doing that study now. They needed to have an FEV1 between 25 and 100% predicted. They needed to be stable, and they needed to basically be using inhaled tobramycin as a maintenance product. So they need to have 2 cycles in the last 6 months out of perhaps 3. They did not need to be using azithromycin at the time of enrollment to the study, but they had to have shown ability to tolerate that in the past. And I'll show you how many were chronic users at the time. And then they had to be otherwise generally stable. We did exclude those with Burkle-Darius-Apatia complex or NTM. Our outcome, so our primary outcome was the relative change in the volume of FEV1 from randomization to the end of that 4-week period of inhaled tobramycin. That's a 6-week time frame. We were also particularly interested in that 4-week period just during inhaled tobramycin use, along with the change in sputum Pseudomonas density, because that really underscored the biological rationale for our question. We had some other secondary outcomes, as you can see there. So who did we study? We were able to enroll about 120 individuals. They randomized a little bit unequally, but that worked out to be okay. You can see the demographic breakdown there, just to note that only about a quarter were adolescents, most were adults and older adults. Their mean FEV1% predicted was 70 to 71%, so this was done before ETI emerged into the scene in the US, and about half and half were using a tobramycin solution or powder product. You can see there importantly that over 80% came into the study on chronic azithromycin use. So what we did in essence was do a withdrawal study of chronic azithromycin in the majority of them. So here is our primary endpoint or outcome, and this is the relative FEV1 change over the 6-week period. And what you can see is that there's, if you note the y-axis, there's relatively small change, but there was no significant difference. And in particular, there was no evidence that those who were not receiving azithromycin benefited more from their inhaled tobramycin product. That change numerically was 3.4%, and it was not statistically significant. If you wanted to know the absolute FEV1% predicted, I'll just demonstrate that. It's a little more intuitive for many clinicians especially. So that difference was 2.2%. Again, not statistically significant, but in favor of the azithromycin group rather than the placebo arm. And that secondary outcome of interest, that 4-week change, is shown here. Based on the figure, it's inconsequential, but it was relatively small and non-significant. I mentioned we were interested in the Pseudomonas changes, of course, and so we had fewer individuals who were able, even at that time, to provide us matched samples of sputum where we could look at the change within individuals in Pseudomonas, but we were able to collect that from over 30 in each arm. And the difference in the 6-week change in the Pseudomonas density was actually statistically significant in favor of those on placebo. If we restrict that to those who came in on chronic azithromycin, so really focused on what may be a withdrawal study, that was a little larger effect, close to a log reduction, which was also statistically significant. There were no differences in symptom reporting in this relatively short study, adverse events, exacerbations, etc. For those who have concern about QTc prolongation, it was an opportunity to measure serial ECGs in a population, not terribly large, but a population, and we did not find any evidence of QTc prolongation in either arm. So in conclusion, in long-standing users of inhaled tobramycin, concomitant azithromycin does not reduce the short-term impact on lung function. Any effect on long-term impacts were not addressed by this trial. In the study population, there was little change in FEV1 in either arm, and that's not surprising. We've known this really from the beginning, studies led by Bonnie, where long-standing users of inhaled tobramycin have a leveling out of that FEV1 effect. Our question was, if you took away azithromycin, might we uncover or recover some of that FEV1 response, and we did not see that. And that was despite greater improvement in Pseudomonas density in those in whom azithromycin was not present. So I will mention very briefly, just a single slide about the manuscript submission process, really from the author group perspective. This was a challenging manuscript to get published. The intervention in the study was actually placebo, and that was a little bit tough for some people to wrap their head around. The results, though they supported this microbiological premise, were counter to what we had theorized or perhaps would find. We're very grateful to the editors for recognizing the importance of publishing what some might consider negative data. I would argue perhaps not quite negative, but interesting and unexpected. The first journal, considering the manuscript, did not allow us to respond to reviewers citing low enthusiasm. I say that not as sour grapes at all. This is part of the process that we all go through, but rather it gave us an opportunity to respond to some very insightful reviewer comments and improve the manuscript before we submitted it to Thorax. And then Thorax provided very thorough review. 3 reviewers plus a statistical review were very helpful reviews that significantly improved the paper. In this case, we had one reviewer who remained concerned and required a very thorough response, 6 pages. I have to credit Nicole Hamblett, who was the TDN Coordinating Center lead and our lead statistician on this. The point I wanted to make here, though, is that the editorial members of the journal were very helpful in helping us understand what were the most important factors to respond to and how we could kind of work through some disagreements between the authors, even our own statisticians, and this particular reviewer. So that allowed the paper to go forward. And with that, I appreciate the chance actually to thank the Teach Study team very briefly, the 39 TDN sites who did this. It was a challenging study to enroll and recruit for, and note Dr. Mayor Hamblett and particularly Pradeep Singh, who did all the blinded microbiology. Thank you very much.
Okay, do you want to hang on for a second? Are there any questions regarding the study conduct and the author experience before we move on to the reviewer experience? And is there anything in the chat or the online questions at all at this point? We could, I think we could, yeah. So thanks very much indeed, David. And I'd now like to invite our reviewer, one of our reviewers, Dutch van de Vanter, to present the other side of the experience, which was reviewing, and I think as Dave alluded, how we manage those review comments to get the best and most rigorous version of the manuscript published.
Great. Well, I want to thank the organizers for inviting me to give the last talk of the last session of the last day of this fine meeting.
It's not my
Oh, yours the last one. Okay. Well, that's only right. But in retrospect, it's probably appropriate because this is going to be the least sophisticated presentation in this entire meeting. I am going to be talking about this article, but I'm also going to really stress my perspectives, not only as a reviewer, but I am also a handling editor for another journal, so I kind of am a wave and a particle here. I have multiple thoughts related to this. How do you advance this thing? Oh, the space bar maybe. Huh? Oh no, jeez. No, that's not it. Oh my God. I was wondering why people weren't just proceeding along, and now I know. What do I got to do? Jesus. That one. Is it doing it? Oh, do I got to go down? This is not a touch screen. Do I do it like that? There we go. Okay. I'm going to dwell on this disclosure slide, which is not the way this works at the meeting usually. Usually you got to read really fast to see the disclosure slide. But there's a couple things about this disclosure that are pertinent to my discussion. First of all, I was employed by the company that developed inhaled tobramycin at the time that it was developed. So, and right off the bat, you might think this guy has got a conflict of interest here. I've been employed by many companies that have developed inhaled antimicrobials, worked on them, some more successful than others. And I think the other thing that I want to stress is that I've engaged with collaborations with most of the authors of this paper, and even more importantly, I consider some of them to be some of my very best friends. And the reason I bring that up is because I can understand how people might think that therefore they are ineligible to review this paper, but I'm going to just stress the fact that that's not the case. So I want to talk about the importance of peer review. As a community, we're really responsible for our literature. There's no one else that's the stewards of our literature. So the transparency, accuracy, reproducibility of observation, interpretation of results, context, that's on us. That's all on us. And we're a small community. The chances are that people that really understand what you've done, you've probably worked with them before. You probably have been in the bar with them last night. And I'm just going to say that knowing someone or having worked with someone on other projects is not in and of itself a conflict of interest, okay? That being said, you have to be rigorous and fair, obviously, and remember that your anonymity is not always assured. It's a small community, and things like this happen, and now we know who the reviewer was. If you have a true conflict, though, and there are true conflicts, you have to, of course, recognize it and recuse yourself. And please suggest another reviewer, if at all possible, to the handling editor. So with respect to the timeline, I was invited in August, and I had the review completed the next day. And that's because I'm an editor and a reviewer. I took one day. It wasn't a 2-line review, though. I really did actually provide a review. And this was really quick. I was pretty surprised. So the authors got a minor revision request within a month. And then actually John LaPuma and I were asked to write an editorial regarding this submission that we did write and that has been published. And in some respects, that's the other thing you need to understand if you're a reviewer. There's always a chance that if it's a particularly interesting or controversial paper or meaningful, that you may be asked to write an editorial. And so think about how a thoughtful review may give you an opportunity to further contribute to the literature. So why was I glad to review Teach, other than that these were my friends? I've just over time come to realize that I don't really understand how or why or when antimicrobial treatments actually produce benefit in CF. And I know there are many of you that know exactly why they do, and I salute you, but I do not. I'm not saying they don't provide benefits. That's not what I'm saying. I'm just saying that we have these very simplistic models that reduction in density of a targeted organism causes benefit. But they're just that, they're simplistic. And our literature is full of associations, true associations, but what we've done is we've spun these constructs out of these associations. We have 2 points, that's a line, it's a linear relationship, okay? That's what's great about articles like this, studies like this, is that they leverage off of constructs and predict an answer that, in this case, as is noted, we really didn't get. This is a pragmatic, multi-center study. I think we need to do as many of these as we can. Very talented and thoughtful group of people, which also makes the reviews better. It's just easier to review a talented group's work. And I just think that a clinical test of a widely accepted construct, I just can't think of anything more enjoyable to review. I think this is a well-conceived test of a familiar construct. And I'll just say it again. If it's true that reduction in Pseudomonas density drives the benefit of inhaled tobramycin, then antagonism between azithromycin and tobramycin should dampen inhaled tobramycin benefit. It's just that simple. That's what should be true. And as Dave mentioned, this really is a azithromycin withdrawal study. Withdrawal of azithromycin should improve those outcomes with 2 provisos. One, that it actually happens in people that azithromycin antagonizes tobramycin, and also that we can adequately measure a change in response. And that's a little bit more challenging, and I think Dave touched on that a little bit, and I'll address it a little bit more. This is more than an academic question. At the time that Bonnie was the principal investigator on the inhaled tobramycin studies, we weren't giving more than 60% of CF patients in the US chronic macrolides. Those studies that were supported by the foundation were run 4 or 5 years later. So we didn't have any data from the primary studies about whether there was any sort of effect of macrolides. But right now, today, 2/3 of patients with Pseudomonas are on inhaled antibiotics, of which, actually they're on inhaled tobramycin, more are on inhaled antibiotics. And they're also taking macrolides, and the majority of them are taking both. It was a pragmatic, but it was an intriguing design. And again, because most patients were already taking azithromycin, this was a really clinically relevant question. We've got all these patients taking both drugs. If we just stop one drug, will they even get better? How great would that be? And we understand inhaled tobramycin withdrawal. It's in the label. Most people do it every 28 days. But macrolide withdrawal not really been studied, and so this is a great opportunity to look at it. And this question, which I really found that very first presentation to be quite intriguing, of whether chronic macrolides continue to provide benefit. It's almost like azithromycin is an antibiotic, and I know that's crazy, but I almost got that impression from that first study. Would it improve outcomes? And I think that's really a fascinating question. These studies can be messy, though. They're very, very messy. But you've got to embrace the mess, obviously as an investigator, but also as a reviewer. You can't say this is not publishable because it's not pristine. It's messy. That's the nature of things. So some thoughts on TEACH. Anybody who thinks this is a negative result is just ridiculous. This is an incredibly positive result. And that doesn't mean it's definitive. But imagine if these guys had seen that removing macrolides gave a 5% FEV1 bump. I guarantee you, everybody would have stopped, right? We just saw the simplified data, and I'm glad don't work for Genentech this morning. So I just think TEACH reinforces what we all should know, but maybe some of us don't know well enough, and that's that our constructs for rationalizing how antibiotics work are just a little bit too simple. And what was interesting, and again, it's messy, not all patients had Pseudomonas density data, but what was clear was there was really quite a significant discordance, I shouldn't say significant, remarkable discordance between how Pseudomonas density went and how lung function went, okay? So they're not inextricably linked, but they've been associated. So withdrawing macrolides actually wasn't a great thing for those patients. In fact, it looked like maybe macrolides actually, admittedly small numbers, overlapping confidence intervals, but macrolides kind of looked like that. They were okay. Withdrawing, maybe not so good. And clinical trials, good clinical trials raise questions. So the other issue here is, are we really measuring benefit, the entire benefit that these drugs give, and is measurement of really what's an acute change in FEV1 a good surrogate for the benefits that these drugs bring? And I just want to point out again, Bonnie, you're on the spotlight here. This is your data. I'm going to call you up to defend it later. In the first cycle of the tobramycin study, there was a really pretty remarkable change in FEV1. But already by the third cycle in this randomized controlled trial, the FEV1 change from off drug to on drug was really quite modest. And there were people that said, I guess it's not working anymore, right? But I don't think empirically we can say that if 60% of people are still on these drugs and they've been on them for a very, very long time. It seems unlikely they're not working. But this measure may not be the best measure overall of a clinical benefit. I just think we need to keep that in mind. There have been other examples, though, of this uncoupling of Pseudomonas density change and lung function response. So this is a study that several of us in the room were involved with inhaled levofloxacin that was compared to inhaled tobramycin in a population that was highly tobramycin experienced. And when you looked at change in Pseudomonas density in this study, even though these people were highly tobramycin experienced, they had a 1 log change in Pseudomonas density that would be favorable, that we would say that should result in a clinical benefit. And it was quite a bit less for the levofloxacin group. But when you looked at the FEV1 responses, what you saw was there was almost nothing going on in the tobramycin group, despite that 1 log change. And there was a bump in levofloxacin, not enough to get it approved in this country, but enough to get it approved in Europe and Canada. So we've seen this before, we'll see it again. We've got to get away from this construct that it's all about Pseudomonas density. I don't know what it's about, but I know what it's not about. So I have a couple closing thoughts. If you're invited to review a submission, obviously carefully consider your conflicts of interest. Your inviting editors may have no idea that you've got a conflict. Why would they know? And if you aren't sure that you could be balanced or fair, obviously you need to decline. But the other thing that you get to do, because you're one step removed from the authors, is to think about how this current observation relates to previous observations and to bigger questions. Remember, we're the stewards of our literature. When we see opportunities to link things together, we need to urge authors to do that in our reviews. Look for opportunities to move the community thought forward, even if it's a challenging thought, like everything you know is wrong. That's a really important thought. If you can get that into a paper, that's really useful. I think good peer review is really the central to CF literature stewardship. We need to urge authors, and where I like to do my heavy lifting, it's not about grammar and spelling, although please do use good grammar and spelling. It's to really think about your limitations carefully. Nobody gets hurt for recognizing limitations. Explore alternative explanations as best you can and try to place your results in a larger context. I think that is the fun part of reviewing, and I think it really makes better material that we get in our literature. And remember, it's our literature, it's our job to do that. So with that, I'll stop and we can take questions.
Thanks for that. So thanks both to Dave and to Dutch for those presentations. And just to pull out a few issues before we take questions, I think this was a clinical problem where the community could have just sat and scratched their heads and said, yeah, that's a hard problem. But actually a group of investigators took up the challenge and did the study. And I think Dave and his colleagues are to be commended for that. And that was something that really resonated when this paper came to our journal. And just to pick up on a few things that Dutch said, the importance of peer review. We mostly know each other in this community, but don't think for 1 minute that if you suggest a reviewer who you might know and you think they'll do a good job, that they're going to be easier on you than one that the editors might pick, because in my experience as an editor, that really doesn't happen. They'll be tougher. They'll be much tougher, the people that know you, than the people that don't. And I guess just to pick up Dutch's point, thank you for doing excellent review, because when I went into BAT and that we were contending with studies on sleep and critical care and COPD, it meant that the CF paper got through because it had excellent peer review and because the authors had responded point by point and taken some time over the statistical response, and that's how we got it into publication. So thanks everyone who was involved in that process. And the final thought is, if you are a reviewer and you get asked to write an editorial, please, please, please make it fun. There is nothing worse than reading a dull editorial. So think up a catchy name that what can we learn from Teach, and put lots of fun stuff in it and try and move the thought in the field a little further forward in that editorial. That's enough of me editorializing. Are there any questions in the chat?
So this one's actually just for the editors, and is there any specific advice for new reviewers, particularly junior ones?
I'll just make a point, and then I can share that one with Patrick and with Bonnie. I think if you're junior faculty, usually you may not get the request. The request may go to your senior colleague, and if that's the case, I think what should happen is you do it together and you get feedback, and it's iterative. And I think that's part of what we should do as investigators to encourage our junior faculty coming forward. The other advice really just echoes what we've heard in this session. Go through it carefully. Make sure that your comments are substantive. Don't get hung up on the grammar, though data are plural. And really try and make substantive points that are going to help. And if it's going to make it, then it's a nurturing process to help the authors.
Yes, I totally agree with you. We really want to find new young reviewers, but we often, don't know where they are. And so if you have a more senior person, ask them, if they ever get asked, can you do it with them? We love it when a mid-level or senior reviewer says, can I have one of the fellows or a junior faculty help me? And we actually, probably most of the journals do, we will write a letter saying that they contributed an excellent review, and that is very helpful in your promotion package to have those letters. So we really do encourage junior reviewers.
And I agree with all of that. The basic things that I need is on the one hand, I do kind of want to know if you think this has merit to be worth be published. I don't want you to tell that to the authors, because I will delete that from your message. But the goal is to what needs to be done to improve the paper, and it doesn't have to be perfect. But what are those flaws or opportunities to improve upon it? Because as Dutch has said, it's about us trying to advance our knowledge and so forth. So a 2-line review, you're probably not going to get asked again. Now maybe that was your goal, I don't know, but unless it was really bad. Yes, but even if like I asked the editorial board, if I send you a paper and you're like, this really shouldn't be published, give me specific reasons why, because I want to share that with the author as to why we're not going to take it on. They deserve some feedback.
Are there any questions from the audience?
I just wanted to make one comment about Dave. I knew who Dave was, but Dave didn't know who I was during this process. But Dave revealed during this process that the paper had gone to another journal that will not be named, and that they got reviews back and a rejection. Now, I don't know how the hoity-toity journals handle that sort of thing, but I'll tell you how the JCF handles that. If you're in that situation and you think those reviews are valid and your material will benefit from them, and my understanding is you actually modified your manuscript, your submission, tell the journal that this has happened, provide the reviews, provide your responses, just like you're sending it back, but send it to the new journal, because as an editor and a handling editor, we learn a couple things from that. We know, first of all, we've already got some reviews. That's really good. But then we also get a feeling for how responsive you are, how this is going to go. And I know it sounds like, oh, if I tell them I've been rejected, that will increase my chance of being rejected, but that's not the way we play this game. So if they're crappy 2-line reviews, don't tell us. But if you got really good reviews, and this happens with these journals, you get good reviews and you think, I could respond to all these, but it doesn't matter, because they say, don't ever send this back to us again. But go ahead and include that, and like it's a revision. And I'm talking about have the track change version and everything. Why not? It doesn't hurt. If you've responded to them and you think it's made it stronger, makes for a stronger submission for the next journal. I don't know, maybe you guys disagree with that.
Thanks, Dutch. That's absolutely true with Thorax, and we encourage authors to tell us if it's been to another journal, been peer-reviewed, and been rejected. We like to see that peer review. Peer review is a precious resource, and we must use it wisely. And if that doesn't happen in our community, what will happen is we'll commission a review for Thorax, and what we'll find is the reviewer says, I have reviewed this for another journal. Not the case in the TEACH example, but in other examples, they say, I have reviewed it for another journal, and the authors have addressed absolutely none of the points that I made previously, and I'm rather frustrated to be reading it again and making the same comments.
Okay, so there's been presentations now from the 3 journals, and so now at the end, each of us, so Patrick, Al, and I, chose topics that we thought would be of general interest with regard to getting published. And let me find it here. So I will go first. Hopefully I'm the first one that comes up here. Oops, what's wrong?
Are you winning with the
Oh, yeah. Let's see if this is the right one. Okay.
Looking good.
All right, so let me see here. Okay, so my topic is going to be choosing the best journal for your manuscript and what considerations you should have. And then I'm also going to touch on the growing issue of predatory journals, which most of you, I'm sure, have had contact with. Now, let me see if I can get this to move forward. Where's the mouse?
So what worked for me was put the mouse on
there.
next slide and then click.
Okay, all right. High technology, thank you. So here are my financial disclosures. I do consult for a few companies, and I receive funding from both the CF Foundation and NIH. So, why do you want to publish? Well, I mean, as I think Dutch very clearly described, we're responsible for our own knowledge base, and so the only way we're going to expand our scientific knowledge and help patient care is to publish. And also, it gives you a peer review, whether you get accepted or not. You get very, very helpful comments at most journals. It's going to support your career, academic career, or your career in general. And it also can increase career opportunities for grant support, national recognition, or can attract colleagues or students to come and work with you because they know what your work is. So what type of journals are going to meet your needs? And so I've gone through several concepts here. And I think that, to me, the most important is that you're reaching the optimal target for your manuscript. I think a lot of people, I will come to impact factor, but it's down the line. You really need to think, is this am I going to hit the best audience? And as my example, I'm going to compare our three journals. So both Thorax and the American Journal of Respiratory and Critical Care Medicine are, as they state, they're across respiratory medicine. And so CF, we have to acknowledge, is a very small part of all of respiratory medicine. And so, as Alan was saying, that means that a CF paper has to compete against COPD or asthma and everything else. And so, if you're going to one of those journals, first you have to realize you're competing with other topics, but also that you're probably going to have the interest of a smaller amount of that audience. I mean, some people will have a general interest. So the Journal of CF has the advantage that everyone is interested in CF, and it's going to be broader than just the physicians. You're probably going to have other health care specialists. And so, for example, if you're looking at something with nutritional management, you may get a much broader audience for your topic. So I think that's an important consideration. Whoops, I'm sorry. I don't know how to go back here. I didn't need to. Second, it's helpful to choose a journal that's well respected, because your peers are probably going to tell you, similar to what Dr. McElvaney said, which is you knew you were going to get a good review. So think about that. And obviously it has to be easily accessible. Now with PubMed and the internet, that's no longer an issue. I'm of an age where you actually had to go down to the library to find them. And you want a submission process that's reliable, well-defined, and ethical. Oops, let's see. Gosh, this thing is crazy. And does the scope of the journal match your area of research? Do you want a broad or a narrow scope? So for example, if you're doing a methodology paper, maybe a new assay, maybe a new statistical method, you're probably going to want to put that in a very focused journal, because it's probably not going to get as good a review. If you're doing something like TEACH, which was a randomized clinical trial, or Optimize, you are going to probably want to go to a broader journal, such as Thorax. And then what types of papers are within that journal's scope? For example, the Blue Journal just doesn't accept most case reports. So you need to look and see if I have a case series, even though it may be very interesting, it has to match the right journal. And you need to look at the review process and the editorial office. So again, if they have a reputation for quality reviewers, remember that reviewers are volunteers. And if they get very interesting papers where you learn something, you can usually get them to sign up. So, you can, depending on the quality and the reputation of the editors, the journal itself, will also impact the quality of the reviewers. And you want to have a reasonable turnaround. Our turnaround at the Blue Journal is usually 2 to 4 weeks. We're under a lot of pressure. We get reminders all the time. But sometimes it's hard, particularly the month of August, which is almost impossible. And that there are clear instructions. So go online and see, are there clear instructions? And you need to actually read those instructions. Look at the governance and longevity of the journal. Is it a society-supported? So Blue Journal is for the ATS. Or is it a commercial? Not that commercial is bad, but if it's a society paper, usually they have a mandate for the type of articles that they publish. Cost, make sure there aren't hidden fees. I'll come back to this on predatory journals. And then, of course, impact factor. It is important, but I think it's a mistake if you use that as your only criteria because you may not be getting the appropriate match with the journal. And the impact factor is chosen redetermined every 2 years. But remember, to some extent, it can be manipulated because it's the number of citations per number of publications. So if you limit the number of publications, you can push up your citations a little bit. In the last 2 years, a lot of the impact factors have gone up, particularly in respiratory journals, because of all the COVID papers, and everybody was wanting to read about COVID. That'll probably settle out in the next couple of years. So what makes your paper attractive to journals? Novelty and impact, I would say, are the two main questions that reviewers and editors are looking at. Is it hypothesis-driven? Does it present new data? And will it change patient care? Will it change our understanding of mechanism of action? So obviously, a prospective randomized trial is going to be considered higher impact than a case report study. Are the methods clear and well developed? Is the discussion and conclusions well supported by the results and not overreaching? And I think that last statement is so important. Among reviews, probably one of the most common things we put in is that you have been promising too much in the discussion and you need to step back and be honest about the limitations. Is it an area of interest and not recently published? This is a mistake I often see is there'll be some articles on a topic. I'm thinking back a couple years ago on microbiome, both respiratory and gut microbiome, and always there's this flurry of these. And so then they start coming in. Well, if they've recently been published, it's not going to get republished unless there's something very novel. So don't make the mistake of going somewhere because you've seen 2 articles on the same thing. Now, I want to end talking about predatory journals. And predatory journals are the systematic for-profit publication of purportedly scholarly content in a deceptive or fraudulent way. And with access to online and the internet, these have gone sky high. They're not to be confused with open access publication, which will be discussed in a minute. They tend to be very aggressive email solicitations. Since I put this together, I've been looking every day. There is not a day that goes by that I don't get 1 to 2 of these. They guarantee acceptance or fast publication. Nobody guarantees publication, so you have to be worried about that. And the real worry is their hidden author fees. So they say they'll publish, but then they charge you. And then if you say, but I don't want to be part of this, then they even charge you more to withdraw the paper. There's lack of any there may not be any peer review at all. And they often publicize plagiarized materials. So how do you get caught? You can say, well, I'm not going to be stupid enough to do this, but they're actually pretty smart. It may not just be that you submit to them, because a lot of what they do is they make their name very similar to a prominent journal. It's just a little tweak on a prominent journal. So you look at it quickly and say, oh, that's a good journal. Or you may be put on or asked to be on an editorial board. In fact, people can be put on the boards and not know they're on the board. So you have to be careful about that. And you also may get invited to a conference, thinking it's a real conference. Alan was just telling me about some junior people in his group who got invited to one of these conferences. And again, you could accidentally submit thinking it was another journal. So, just keep keep your eye open. There are 2 websites that can help you. One is jane.biosomatics.org, because that will list what are legitimate journals, and also thinkchecksubmit.org does the same thing. So don't ever submit or go on to an editorial board before you've checked, and then obviously ask your peers or your senior mentors. So in conclusion, I think finding the right balance is very important, because on one hand, you may be coming up for promotion or, feeling pressure, and so you really want to get a paper out. And, if you aim very high, you have the chance you'll get a great review, but you may not get accepted, and then you're going to have to go through the process again. And you have to realize that could end up being maybe months. So you have to weigh that against, if this is your most important work, you want to get it out to as large an audience as possible, and you may be willing to take the chance and the time. And even if you don't get accepted, you'll get a great review. You can use that review when you go to the next submission. And as Dutch said, I would agree, take that information and that advice and be honest about it. Within the blue journal is part of the American Thoracic Society, or ATS journals, and there's the blue, the white, and the red journals, and often you'll be directed from, if you don't get into the blue, you'll be directed to like the white journal, and the reviews will be automatically transferred. So that information is available. You don't have to make that choice if you don't want to. So I think with that, that's my things, and do we have questions of me before we go on? Yeah. Has this been recorded? Yeah, I believe it's being streamed.
It should go to every professional intern.
Yeah. Yeah. Thank you. Okay.
So thanks for that, Bonnie. And we're going to continue the series on sort of new things in publishing and things to watch out for and tips for submitting to journals. And I'm going to talk about preprint servers. And I've called this a rush to publish, or just-in-time delivery for science. And the rush to publish comment was made by a senior editor now at JAMA, commenting on the rash of preprint servers that have appeared and questioning whether speed was everything. So I'm just going to walk through some of the issues with preprint servers, introduction to them, why would you want to publish a preprint, and some considerations both for researchers submitting to a preprint server and for those reading and interpreting those papers. See if I can manage the IT this time. These are my disclosures. So what is a preprint? Well, this is from the Committee on Publication Ethics. A preprint is a scholarly manuscript posted by the author in an openly accessible platform, usually before or in parallel with the peer review process. And the standout from this, obviously, is that preprints generally are not peer reviewed. And that has important implications for everyone involved in the process. And indeed, this is a disclaimer that is used by medRxiv. Preprints are preliminary reports of work that's not been certified by peer review. They should not be relied on to guide clinical practice and shouldn't be reported in the news media as established information. So if you publish on medRxiv, which is one of the biggest preprint platforms, it comes with that very clear health warning. There has been a proliferation in preprint servers. So this BMJ Open paper describes 47 preprint servers and 2.7 million preprints available on those servers, and that was in 2020, and I'm sure the number is very much greater now. And I've just given you a flavor of some of the platforms you might choose if you're wanting to send in a preprint. And I'll walk through how they're a little bit, the examples I've given are a little bit different from one another. So at the bottom, we've got Cell Press. So if you're submitting a paper to Cell, there's an opt-in process whereby you can ask for your manuscript, which has not yet been peer reviewed, to be available whilst the peer review process goes on. And in red against each of those, I've put the number approximately of preprints available on each platform. This was a few weeks ago when I prepared this slide, and it will have increased since then. In a big contrast, you've got the Lancet at the top left, which has a very clear disclaimer that says, we host preprints, these may not be under review by the Lancet and may not be published by the Lancet, so they're not giving anything away. On the bottom right there, we've got the Wellcome Trust Open Research Platform. This is specifically for Wellcome Trust funded research, and it's probably a way of ensuring that there is less research waste because all data are published. And then top right, we've got medRxiv, which is fairly new to the field. It's supported by a consortium, the British Medical Journal Group, Yale University and Cold Spring Harbor. It began in June 2019, just before the COVID pandemic, and for medRxiv that was fortuitous. One, I guess, thing to think about is if you choose to publish in a preprint and then it goes on to become a journal publication, does the preprint step help you at all? So I've just given as an example a paper that we published first as a preprint and then in JCF. And many preprint servers will give the option for a kind of crowdsourced peer review. There's a comment section where people can wade in with their opinions on your paper. And I can say truthfully that our preprint of this paper produced not one comment at all. So there was a resounding silence to our preprint publication, but actually in comparison, the JCF publication produced citations and social media activity and lots of interest. I don't think we should draw too much conclusion from one example. Another thing just to flag up on this is that if your preprint then goes on to be published in a peer-reviewed journal, that will appear on the preprint, so anyone reading the preprint is then aware there's a peer-reviewed version of that, but both versions will have a digital object identifier, so they are both standalone publications in perpetuity, which will be similar but not identical. So does this crowdsourced peer review process ever work? Does it ever do anything? Well, yes. Here's an example. This one is from bioRxiv. So this was at the height of the COVID pandemic, and this group published a piece of work suggesting that there was a resemblance between the COVID-19 virus spike protein and the HIV surface proteins. And this received well over 100 sort of crowdsourced peer review comments. You can see in that little speech bubble box at the bottom. And most of these were critical, and indeed this article was withdrawn as a result of that. So the crowdsourced peer review can work. Just to bear in mind, this has been used in the physics and mathematics literature for a very long time. So arXiv is the kind of prototype of all preprint platforms, and many mathematicians and physicists don't see the same need for peer review publication because they can get their work out and share with the community through the preprint server. My top tip from this example is never use the word uncanny in the title of a scientific paper, because really it won't go well. So what difference does peer review make then? So if we compare the peer-reviewed version with the preprint version, what differences might we see? And this is a piece of work that was done at the height of the COVID pandemic, published last year. They looked at papers in 2020 where there was a preprint, but there was also a peer-reviewed publication. And what they were particularly looking for was spin. So to what extent had the authors made conclusions that went beyond their data? And when they compared the two, they found in about a third of cases, both the preprint and the peer-reviewed publication were spinning at least one outcome. There was a slight, in those where it only appeared in one or the other, it was slightly more common in the preprint, but it certainly doesn't suggest that there's a huge problem with preprints in that they're overselling their results. So why would you want to publish a preprint? Well, one reason is scientific precedence, and you might wonder why I've given a novel by William Boyd as an example of scientific precedence, but I urge you to read Brazzaville Beach because it's a really great read, and it takes the issue of scientific precedence. In this case, it's about a naturalist observing the behavior of a troop of chimpanzees. And the naturalist, the junior researcher, observes behavior which is quite out of range of what has been reported previously, and specifically goes completely against the teachings of her mentor and senior researcher and leader of her group. And her work is suppressed until the dust settles, at which point the leader of her group publishes the work as his own. Now, if the protagonist in this novel had had the foresight to publish a preprint in Brazzaville Beach, then that wouldn't have happened, but then I guess there wouldn't have been a novel. It may help you support an upcoming grant application, so you can get your work in the public arena quickly. It promotes collaboration within research communities. That was particularly important during COVID, and also important during COVID. You can share time-sensitive findings with your community, but a great caution about you should not use those findings when they exist only as a preprint to guide patient care. So my top tips are consider publishing a preprint of your work ahead of submission to your target journal, but check the instructions to authors for your likely target journal or journals. Make sure that the license, the publishing license, is compatible with journal publication and that journal allows prior preprint publication. Choose a reputable not-for-profit preprint server, just picking up on what Bonnie has said, and will be read by the audience you want to reach, and disclose when you submit to the peer-reviewed journal that you have a preprint of your work and it's already out there. And so just to close, I've just stepped down as one of the 3 editors-in-chief of Thorax, so I want to thank my co-editors. You can see here from this meeting that we were experiencing a profound sense of loss and heartbreak at the end of our 7-year tenure as editors of Thorax, dealing with 50 manuscripts a week. I thank all of you for listening.
Any questions for Alan? Okay, this is the end. And I recognize that I am the last thing standing between you and the social event. So, I'm going to talk about open access. And these are my disclosures, but honestly, none of them have anything to do with what I'm going to talk about. This is a slide that I stole from an editor of JAMA about this whole notion of open science that really encompasses a lot of things, but I'm only going to talk about open access with respect to publishing. There's a lot to talk about with other, issues of transparency, and it's all well intended, but it all comes with baggage. So, a brief history of open access. In the beginning, the journals were all a subscription-based model because publishing, everything was in print, and so you subscribed, often through memberships. So the first major disruption was the internet, because now it enabled online access to your library subscriptions. But mostly everything was behind a paywall. You had to pay to be able to see what was behind it. The next disruption was the establishment of these open access only journals built upon the principle that everything would now be available to the readers, and the business model was supported by article processing charges. So you would pay money and you would make it available for everybody. And where the open science thing is, it's becoming increasingly mandated by funding agencies. There are some that are just insistent that it must be made available right away. And I don't have time to go through the whole history of it, but there are some large groups that have, try to put their line in the sand as to what needs to be done, really just over the last decade. But Plan S is probably the one that gets the most press. And they've made some sort of mandates. I will tell you, they've softened on some of these, but they said everything must be available immediately and freely available. They were not supportive of a hybrid model, which I'll explain in a moment, and that the fees to publish needs to be fair and reasonable. Our journals, the three of our journals, are really best described as a hybrid model. And what that means is that, it's a subscription journal, and so most of the published papers are available to those who subscribe to it or who are willing to pay a fee to get behind the paywall to download it. Generally speaking, that's not forever. These papers are embargoed for some period of time, and then after that time, they're freely available to everybody. In all these journals, though, three of our journals, there is an increasing number of papers that are actually open access. And so that's what I mean by hybrid. You have some papers you can see freely and others that you cannot. And I've just given you some numbers of what you see in JCF. We don't really, the COVID stuff is a little bit different. And the general estimation that of these type of journals, about a quarter of papers are now considered open access. So there has been this trend over time. And to get to this point, publishers have provided something that they call transformative agreements. And essentially they're offering, instead of not really a subscription, but to an entity, they will provide you a certain number of publications and a certain number of downloads that you can purchase. And in general, there'll be some kind of quota approach to that. So your institution can have 1,000 publications and 15,000 downloads. Some of them might be a discount that the institution would pay some fee and they'll get discounted rates for publication or downloads. These are a little bit easier for journals that are commercially owned, or the publishers are commercial publishers, but really for scholarly publishers, like the American Medical Association, the European CF Society, ATS, the BTS, it's really not the most viable of options. It's not the easiest thing. So Elsevier, who is the publisher for JCF, has increased its number of transformative agreements. For example, there are more than 20 that were signed in the last year. And this might be a font size that's a little too small to see, but you can see some of these are country related, where the countries have insisted that's how the relationship will be. Others are institutional, or in the US, the California schools said we're no longer a subscription, so we'll move to a transformative agreement. But this comes with challenges. The basic premise behind those who support open access says there's enough money in the system to pay for it, because it's all going to subscription. So we get rid of the subscriptions, well, there's plenty of money. Well, but who has that money? And honestly, there needs to be money to manage the publication. There's a lot of work that goes into it. There's a lot of volunteerism, as Bonnie has reminded us. Even on the editorial board, we're not paying our editors. But there are a number of revenue streams that support those publication costs, and those come in the form of subscriptions, open access fees, downloads, advertising. And so if we just look at those, if we go to completely open access, there's no need now for a subscription because the papers are readily available. And that might be detrimental to societies where part of the package you get for your membership includes your subscription. Now, keep in mind that these societies actually do a lot for the benefit of what we do. They might pay for grants, they might pay for fellowships, they support the meetings, they do a lot. But when it comes to the individual who's making a decision about whether they want to be a member of that society, they're looking at, well, what do I get? I don't need the insurance benefits, I just want the journal. Well, there might be a lot of people who decide they no longer need to be part of the society, and that would be very detrimental to many of them. Open access fees, if that becomes the only revenue source, who's going to pay it? So if your institution were to go into a transformative agreement, they basically would decide, someone in that institution is going to decide whether you get to publish your paper or not. Because they only have so many widgets to hand out. And so it's one thing if you're, say, I want to publish the top line results of TEACH or STOP2 or whatever. But what if I did an analysis of the registry data that, it's an unfunded project? They may not think it's so great. And so for junior faculty, there'd be a lot of papers that probably wouldn't get supported. Same for downloads. Who gets to download that? If it's going to go into grants, and I can tell you that some of the granting agencies are going to say, we're going to permit you to put that as a direct cost in your grant. They're not going to increase the size of your grant. So if you put in publication fees, you're just eating up some of the other direct costs that might be used to support your infrastructure, your animals, your whatever you might need to conduct those studies. And I'm not sure how much they would permit you to put as a budgetary item. So I'll use STOP2. We've published 5 papers already. And we have probably 4 or 5 more that are, I hope, near completion. I'm not so sure that a granting agency will be excited if you say, well, I want to put in $50,000 for publication fees because I think there'll be 10 papers out of this. So I think it's a bit much to think that grants are going to be the full source. So downloads, there'll be no more revenue for downloads because they're totally open access. And it's a little bit unknown what would happen to advertisers. I mean, that's the Twitter funding sources, advertising and so forth. So I don't know how that would be about wanting to be on the websites, but they certainly wouldn't be in any kind of print. And then on the flip side, again, it all seems intuitively obvious that the more immediate that we could have this knowledge out there, the better it would be for patients. But actually, what's the evidence that that's the case? I've not seen anything for it, and I can assure you that during the COVID era, there was a lot of information that came out that was to the detriment of our patients because of the rush to get it out there. And then all of this isn't being discussed in countries that can afford it to some extent, and it will be a real problem for these low-income countries to be able to manage these kind of costs. It's great that they may have greater access to some of these publications, but I'm not sure they would be able to contribute. So again, I think it's a very well-intended idea to have open access and freely available data that maybe we could all use it and be better, but I think there's a lot of hurdles to it that make it far more difficult to swallow. So I will finish there and entertain any questions about open access, or if there are any other questions that you want to put to any of the 3 of us about publication in general.
This is more about data availability. I've noticed recently that, when microarrays first came out, and there was a repository at GEO that you could deposit your microarray data, that most journals said, your microarray experiments had to subscribe to a certain, thing, and so there's a plethora of data in there. But now I've recently got an interest in looking at cell-free DNA as a diagnostic tool for pneumonia. And there's a lot of papers coming out from Asia that use that technique. And the journal policy is actually depositing the NGS data in a database, and there's no accession number, no data availability statement. And so you write the editor and you just get no response. And one of these is Frontiers in Microbiology, right, which is thought to be a pretty reputable journal. So how do we as a community fight back about this data availability, because I think it's really important to really vet these, types of data and see are they, one concern is that there's human DNA in there, but that can be bioinformatically subtracted out now, right? So
Right.
they could just post the non-human DNA, but because our hospital uses cell-free DNA sometimes as a diagnostic tool, but it's still questionable use, right?
So I'll take first crack at this, and really I want to take sort of 2 points. One is that there are journals who do require you to submit the data that they are now going to house. And there are actually some journals that require you to submit your programming code if you've done a certain type of analysis. I can't answer to how easy they make that accessible. Obviously they want it for their reviewers, but I don't know if they're making it freely available. The second part is in the U.S. anyway, the feds have decided that, well, the president's administration has decided that all federally funded data will be available to everywhere for anything that was funded after January of 2023. Again, this is well intended, but it comes with baggage. Now, nothing has to be up until your grant is done or the paper is published, and then it's supposed to be immediately accessible. And every institution is now vetting platforms of how they're going to do this. I can tell you at our institution, some of the discussions the basic scientists have shared is, some of these data are like in Excel files, but they mean nothing unless you have the gels to go with them. And I'm not a basic scientist, so I may be saying things that will be gibberish, but they're not. Whereas clinical data, might be very useful for people to get into if they're large data sets and they know how to analyze them. What that means is that once you post your data, someone could analyze it and write a paper on the question before you do. So you don't get to embargo your data because you haven't finished your analyzing your data. It's once the grant's done, you're supposed to post it, so you have to be done with it. And I worry about malfeasance, that people will analyze data the way they want to analyze it, and although there may be well-intended and they'll double check things and find flaws in the way analytics were done. But I'll go back to the early COVID, and the first ivermectin paper was problematic because they excluded some of their data that actually would have made it clear that the drug doesn't work. So again, it's a well-intended thought. I don't know how it will really improve things. It's almost like CT.gov. It was a federal mandate to try and get these data out there, and I can't tell you if CT.gov has been to any benefit of the world in this sense. So I'll let Bonnie or Alan respond as well.
I think you've picked up a really important point, and I kind of so the essence of science is reproducibility. So making the data available so others can reproduce the work is important. We faced this issue in Thorax, a related but slightly different issue, in that we were submitted a paper that was 25 pages, and it came with an online supplement that was 200 pages. And we have talked about how peer reviewers are doing this in their own time and they're volunteers. Well, we can peer review a 25-page paper, but we can't expect our volunteer peer reviewers to peer review a 200-page online supplement. So we wouldn't publish that and call it a peer-reviewed piece of work. So their option was either not to publish the supplement with us or to find, their option was not to publish the supplement with us because we couldn't peer review it.
No, I agree with it. I think you have one.
Oh, yeah, sorry, this might be something that other people in the room have seen as well. From Ryan Thomas, I recently submitted a paper where one reviewer asked me to add a number of references that were only tangentially related to my topic, but all of the references had a common author who had reviewed for the journal before. How would you handle this as an author or an editor? This was not one of your wonderful journals.
You want to take that now?
Yeah, so speaking for our journal, we can see that. I mean, it gives us a chuckle in the hanging committee, but we would give a steer, I think, to the authors that we always give a steer. Often reviewers will make conflicting comments, so we have to say which one they need to follow. And the same, if there's something that's really obvious, that it's please cite my papers, I think we would advise the author not to follow they didn't need to do that. And I think, as one of the other speakers said, we don't always go back to the reviewers if we've had a really good response. So, they won't be in a position to insist on that.
It's a quick way to figure out who the reviewer is. Yeah, no, when we look at the review, sometimes statements will be made, and if we don't think they should go out, then, as someone said, if you say, well, I think this should be accepted or not, we delete those things. But if it's unreasonable, we usually will delete it or soften it. So you don't have to feel that you have to respond to something you're opposed to.
Yeah, well, just one defense of a reviewer like that is there are occasions where there is a recent paper that actually does address something that's relevant, and as the editor, you can know that the reviewer is not an author on that paper and to judge whether it's fair. The other thing I would say to any authors, just write to us and ask us a question. Is this something I really need to do? Because on the flip side of that is, I would say I'm more inclined to reduce the number of references that people have put in, because they've, if you've got one reference that clearly cites something, you don't need 5 that all have addressed it, unless each of them is adding something novel to that. All right. Well, I want to thank you all for sticking it out. The meeting is officially brought to a close, and enjoy this evening event.
Thank you.